Okay, so let's talk about managing procedural pain, because what's the biggest thing people are afraid of in having any treatment done? What's the first question they ask? Doc, is this going to hurt? And my flat, tongue-in-cheek response is, don't worry, this isn't going to hurt me a bit. But thank you for your concern, I appreciate it. And right there, that kind of breaks the ice, and they appreciate the humor. But they are concerned about it. So what can we do about patient anxiety? What are some of the things that cause pain? You know, it's the tissue deformation as you're putting injectate in there, the pressure of the changes within the tissue. And then what is the injectate itself doing that could be causing pain? So in terms of patient anxiety, what I really like to do is, in a former life I was a marriage and family therapist, so I tend to be a little bit of a hand holder. So I really walk patients through this every step of the way. And they really seem to like it. Once in a while, I have a patient who says, Doc, don't talk to me, just tell me when it's done. They put their earbuds in and they just zone out. Almost everybody else really likes it when I say, I'm going to walk you through every step of the way. I'm going to tell you what I'm going to do and what you should expect to feel. And I go very slowly, very deliberately, and almost universally, they really appreciate that slow, deliberate approach. So I use layman's terms. I try to avoid medical jargon as much as possible. And I tell them exactly what's going to happen. And I agree with Amadeus here. I discourage them from watching YouTube videos. I love it when people go online and read about their condition, because that shows that they're educated, or they want to be educated, they're invested in their condition, they want to be a partner in their healthcare. It gives me an opportunity to dialogue with them about why this is or is not a good treatment. They say, Doc, I read that. All right, let's talk about that. But I say, don't watch the videos. There are some videos out there, particularly by a doc out in Chicago. His videos are barbaric, absolutely barbaric. And if patients watch that and they're like, why would anybody in their right mind want to have a treatment done that way? And I said, that's not how the majority of PRP and prolotherapy is done. So don't watch those, okay? Unless they're ours, okay? Help them to understand what's going on, okay? And then distraction. You know, while I'm doing the injections, we're often chatting a little bit, or I have some music in the background. I've got my little, echo dots in each room, so I can play some nice smooth jazz or whatever they like to hear during that. So that's one of the ways to help with the anxiety. For those people who are really squirrely, I give them a little bit of Valium, 5 to 10 milligrams an hour before. Obviously, they need a driver. Or I like Klonopin a lot. Some just anti-anxiety, just to kind of quiet things down. They need a driver. The other thing that I use quite a bit, this is my slide, this is not Dr. Mason's slide. I really like the use of nitrous oxide when people are anxious. This particular system here is about $6,000. We charge patients an extra $100 to use it. The thing I like about this is it's an anxiolytic. Really helps with the anxiety. It is an analgesic also. It is not conscious sedation. You don't need special training or a special license or anything special with your malpractice to use this. The reason is it's a fixed ratio of nitrous to oxygen. There's no way that you can change those ratios to get into dangerous zones. You just turn the machine on, the patient breathes through the tube. It is patient self-administered. That's a requirement for using it. Patient has to hold on to the tube. They're in control. You're feeling anxious, you're feeling pain, you breathe in and out nice and slowly and deeply. And they love it. And the nice thing is, once they stop breathing, within 5 minutes, all the effect is completely worn off, they can drive home. This is a great, great system that we use. Okay? So that's another way to help with the anxiety and the pain. Okay? Dentists use this a lot. The difference with the dental machines is that they can vary the amount of nitrous and oxygen. That's where you can get into trouble, and you need to be certified and trained to do that. Not with this system. I can talk about this later outside. I'll tell you more about it. Okay? Local anesthesia. I like to minimize the amount of pain as much as possible. So I raise a little lidocaine wheel on the skin. I also numb the subcutaneous tissue. When I'm doing a joint injection, I numb all the way down to the edge of the capsule, because the most pain-sensitive structures with the joint are the skin and the edge of the capsule itself. So unless a patient is hyper-obese, I can use a 30-gauge 1-inch needle. I go in the lateral suprapatellar approach. I can get the skin all the way down to the capsule with a 1-inch 30-gauge needle. And you go in very, very quickly. Most patients don't even feel the needle go in when I use that 30 gauge needle and go in quickly. The other thing that I do is I use a buffered solution. I don't use the 10-to-1. I found that that's really not that effective. I use a 2-to-1, 2 of lidocaine, 1 of bicarb, and it works great. Completely buffers the burning of the lidocaine. It does not adversely affect the effectiveness of the lidocaine. So we use 8.4% bicarb with that, okay? Bupivacaine. I don't even have bupivacaine in my practice. It doesn't even exist in my office. Bupivacaine is highly chondrotoxic. It's highly myotoxic as well. So the only place I could even reasonably think about using bupivacaine would be in a bursa injection, but we don't even have it in the office. We use ropivacaine for our long-acting anesthetic. It's more expensive, but it's much less toxic. He talks about warming the anesthetics. I've never had to do that. I mean, ours is room temperature anyway. We don't keep it in a refrigerator. That hasn't been an issue, but that's something to think about. And then allowing adequate time. You know, you numb the skin, you numb it, wait a moment before going in. Okay, so that's just some simple things here. Okay, smaller gauge needles. I use the smallest needle possible to get the job done. Like I said, for my local anesthesia, I use a 30 gauge needle. If you've ever been injected, there is a difference between a 30 gauge and a 27 gauge. I do what I want done to me, and I'm a big wuss. So, you know, 30 gauge needle, you barely feel that. It's basically an insulin syringe almost, okay? The 30 gauge needles are slightly more expensive, but for the patient comfort, I think it's well worth it, okay? For, if you're doing multiple sites, it depends on what I'm doing. If I'm doing bilateral joints, I will change my needle for my local anesthesia. I don't ever want there to be a consideration of transmitting a surface bacteria from one side to the other into a joint by using the same needle. But if I'm going into multiple areas for soft tissue, I'll take that 30 gauge needle and I'll numb up several locations with that 30 gauge needle. Okay? I'm not worried about a joint infection. Okay? That's just my protocol. Of course, we're cleaning the skin with chlorhexidine and whatnot. Keep in mind though, if you're using that same needle, it will start to dull after a while. So sometimes switching the needle is helpful. Okay? Oh, by the way, he makes this point, and I completely agree with this. Whatever needle you use to draw up your solution, do not use that needle to inject with. 1, it dulls quickly. 2, you also don't want to run the risk of contamination, back and forth. There was a dentist who got arrested and was convicted because it caused a lot of infections in patients. He would draw up a medication, inject it, and then I think he changed the needles, but he used the same syringe to draw more out of the bottle. You never ever want to do that. If you need more anesthesia, get a brand new syringe and draw that up. Don't use the syringe that you just injected to stick it back in the bottle. You can get cross-contamination that way. It's not worth it. For a few pennies of what syringes and needles cost, it's not worth it. Okay? In terms of injection technique, injecting at a 90-degree angle as compared to a 45-degree angle, I don't think that's as important as the speed with which you go in. I used to be a phlebotomist before I went to medical school, and I could do a blood draw basically pain-free. The secret is the faster you go in with that needle, the less it hurts. It doesn't matter whether you're going in at 90 or 45 if you're going in quickly. If you go in quickly, it's like throwing a dart. You barely feel it. But if you've raised a lidocaine wheel, it doesn't matter. Then you go in any approach that you want. And depending on your technique and your ultrasound, if you've got an ultrasound probe here, many times you can't come in 90. You have to come in at an angle to get underneath your ultrasound probe. But as long as you've anesthetized the skin, the patient won't feel that. Okay? And as I said earlier, I try to anesthetize a track all the way down. So if I'm doing a hip injection, for example, I've got sometimes 3-4 centimeters that I have to get through. I'll get my 22 gauge, 3.5-inch needle, and I'll numb the skin with my 30 gauge needle, put my 22 gauge 4-inch needle on the anesthetic syringe, and I'll anesthetize slowly, pushing the anesthesia ahead of the needle all the way down to the edge of that hip capsule or the shoulder capsule. And then I wait a minute, and I inject around the capsule. Now my needle is not only in place for my injection, but the patient's been anesthetized all the way on down. So I can do a hip or a shoulder injection, the entire thing almost pain-free. Just to take a little bit of time and use the anesthetic. Okay? Slow injection, You know, if you go in fast with the lidocaine, it tends to burn, it tends to sting a little bit. Just go nice and slowly, take your time. You know, this is not a race. Okay? I've never done the pulsed injection. I thought this was interesting. You know, put a little bit of a dollop in, wait a moment, inject a little bit more, wait a moment. I've never done that, but that's another technique to minimize pain. And obviously the distraction, scratching or rubbing aggressively with your alcohol wipe or your chlorhexidine wipe before you do it, all can be helpful. Okay. In terms of mixing lidocaines, the only time I actually do this is when I'm doing aesthetic procedures. We use a triple anesthetic cream, benzocaine, lidocaine, tetracaine, for the skin or for the hair, because I do PRP for facial rejuvenation and for hair growth and for erectile dysfunction. So we put a topical cream on, and that seems to blunt when we go to do any local anesthetic injections. So that can be helpful. The downside with that is you have to put that stuff on at least 30 minutes, usually an hour before. Most of us don't have the ability in our practice to do that and have a patient sit somewhere with cream on their face or, you know, on their hair or on their penis or whatever. So, okay. Ethyl chloride spray, I don't like using ethyl chloride spray personally. One, it actually burns when the skin freezes. With my technique, with my 30 gauge needle for local anesthesia, that actually doesn't hurt. Ethyl chloride, if you've ever had sprayed on you, it burns. And the downside is it doesn't get the deeper tissue. So with a 30 gauge needle, I can get the skin, subcutaneous tissue, and I can go as far as I can reach with that 30 gauge needle. And it doesn't burn like the ethyl chloride does. Also, if I have to take the needle out to reposition, the skin is still numb. Whereas with ethyl chloride, I got to spray again. The other reason I don't like ethyl chloride is it's an industrial carcinogenic solvent. For the patient, that's not an issue, but if I'm standing all day breathing that stuff, I don't want that stuff in me. So I don't use the ethyl chloride. For those of you who use it, God bless you, I'm not telling you not to, but that's the reason that I don't. Okay? All right, in terms of the actual injection, I do agree. I inject slowly, I aspirate slowly. The difference is when you're doing a bone marrow aspiration, you do not want to aspirate slowly. The faster you pull back on a bone marrow aspiration, the more stem cells you get. That's been shown in studies. We've actually done those studies and looked at our cell counts, and that's been verified. Okay? But when you're injecting, I go nice and slow and steady on the therapeutic injection. Okay? In terms of inflammatory reactions, you know, depending on what you're injecting, there really shouldn't be that much immediate inflammatory response. You know, some of the leukocytes are pro-inflammatory, your granulocytes in particular, but that's going to be a little bit more of a delayed response. In terms of the pressure changes, that's what most people feel when I'm injecting the sacroiliac ligaments, for example. What people feel is the pressure of the medication going in. Anesthetics will numb pain, but they don't numb the pressure receptors. So I tell them you're going to feel a pressure cramping sensation. You're not going to feel pain. You're going to feel the pressure, the cramping. And I said as soon as you get up and start walking around, all of that will go away. And they go, oh yeah, I feel that pressure. Oh, it's tight. And then they get up off the table and start walking around. They go, okay, it's easing up, it's easing up. So as long as you tell them what to expect, okay? The other place where pressure is really uncomfortable is in the small joints. The hip, the knee, the shoulder, most people don't feel the pressure there, even the ankle or the elbow joint itself. But in the soft tissue a little bit and in these small joints, boy, you know, I inject just until I see the joint starting to distend. They feel that pressure. And unless you do a digital block, there's really not much that you can do about that. Fortunately, it's very short-lived, and once they're off the table and working it around, they're fine. Okay? Again, I don't use bupivacaine. It's very, very toxic. Okay? People have asked, do you add anesthetic to your PRP or your stem cell solutions? And the short answer is yes. And people get confused because they say, I thought that was toxic. You shouldn't do that. No, it's a dose response. This is work that was done by Chris Centeno out in Colorado. And what they did was look at the effect of different strengths of anesthetics on mesenchymal stem cell adherence. Okay, so what's the adverse effect of anesthetic? And here they're using quarter of the strength. So instead of using 1 cc of lidocaine, they would use a quarter of a cc of lidocaine. Here, this was 50% strength. So they'd use half a cc of lidocaine instead of 1 cc. And what you're looking at is what's the percent of adherence. Higher is better. You can see here that the stronger the dose of the anesthetic, there's almost no adherence. Of these, the best was the ropivacaine. Had very, very little effect. And you can see that across the board, ropivacaine has the least deleterious effect on your cells. The worst one is going to be the marcaine. Marcaine just kills everything. Marcaine is bupivacaine, I'm sorry. Okay? I have to use generic names here. Okay? Lidocaine's also not that great. Here, lidocaine is okay, but you're using an 8th strength lidocaine. Okay? So the bottom line here is, for me, in my PRP, we typically make a standard 5 cc's of PRP. I use 1 cc of ropivacaine per 10 cc's of PRP. Or half a cc of ropivacaine per 5 cc's of PRP. Or per 5 cc's of bone marrow. Perfectly safe. And what that does is it helps take the edge off of the discomfort from that treatment. I do like putting anesthetic in my solutions. You just have to make sure that this is not in your slide deck, because I just found out last night that I was giving this lecture and I wanted to put this in here. I can send this to you if you want it, just email it to me. Okay? In terms of post-treatment, again, during the treatment, if they're really squirrely and anxious, I'd give them the Pronox, okay? Or the nitrous oxide. Okay? For post-treatment, we give them a prescription for tramadol. I say, do not let pain be your enemy. Don't be a tough guy and try to tough it out. Pain inhibits the healing process because of the neuroendocrine immune response. Pain inhibits healing. So don't be tough. If you feel that it's getting a little uncomfortable, take the tramadol. Especially take it before you go to bed tonight. I don't want you waking up at 2 in the morning with pain. It's more important that you sleep. Take the tramadol. Okay? If they really need it, let's say I've done a really extensive treatment, intraosseous, ligaments, everything, I'll give them a Percocet. I'll give them an oxycodone. Just 2 or 3, just to give them over that first few days. That's it. I don't want them being in pain, because that inhibits the healing process. Okay? We'll talk about the rehab protocol in just a moment, but I encourage early mobilization. Okay? In certain cases, I discourage weight bearing. There's a difference between weight bearing and immobilization. You can be non-weight bearing, yet still move that joint around. There's a group at Harvard that did an interesting study that showed when you immobilize the joint, most of the stem cells that you inject die. They need movement to talk to each other. It stimulates the paracrine and autocrine activity. Okay? There are a few exceptions. If somebody's got a big labral tear or a big rotator cuff tear, and I'm filling that with a graft material like adipose, I don't want them moving it around and squeezing that graft out of the area, so I'm going to immobilize in those cases. But for a routine osteoarthritis, routine tendinopathies, inject it. Just don't be stupid. Don't go back to playing sports right away. Just your normal daily activities are okay. All right. No anti-inflammatory medications generally. I can't say the data is really, really hard and fast on that, but because of the way it affects the arachidonic acid pathway, we are relying somewhat on that pathway to stimulate a healing response. So I don't want them using the anti-inflammatories. Everybody who does regenerative medicine that you ask is going to give you a different response. I know because we had this discussion recently online. What do people do in terms of restricting the anti-inflammatories? I've heard everything from a month before to 3 months afterwards. I do a week before to a week after, and that seems to work fine for me. Okay? Particularly people who have underlying rheumatologic conditions where they really need their NSAIDs. I don't want to have them off it for too long, but that critical time for me is the week before to the week after because of the inflammatory response phase. It's that really first week to 10 days is the critical one. Okay? I use Tylenol and I use tramadol as mentioned here. Okay? In terms of post-care, when can we shower, when can we do these things? If all you're doing is PRP, no restrictions. Go about your life. Okay? Take a shower, take a bath, do whatever you want to do. Where I put the restrictions in on bathing is when I'm doing harvesting techniques, bone marrow and adipose, because those are minor surgical procedures. So no shower for the first 24 hours, sponge bath. No immersion for the first 3 days. No hot tub, no pool for the first 3 days when I'm making a puncture wound. Okay? After the 3 days, they've granulated and they're fine to go in. Okay? Do we need a dressing? For PRP, standard Band-Aid. For my bone marrow, what we do is a steri-strip and then a tegaderm over the top of it. For our lipoaspiration, we do a steri-strip and then we put a folded up gauze pad under a tegaderm, because sometimes when you do liposuction, the tumescent fluid tends to leak out a little bit, so that gauze underneath the tegaderm absorbs that. The tegaderm stops the leaking. So that's what we use for that. I don't usually put any antibiotic ointment on it at all. Never found a need to. In all the years that I've been doing this, we've never had an infection. So there's really no need as long as you prep the skin properly with chlorhexidine. I keep mentioning chlorhexidine, by the way. I don't know what you do, Ricky, but I don't use betadine anymore. Does anybody know how long it takes betadine to reach maximum antiseptic properties?
To the point of drying.
To the point of drying, which takes how long? 3 to 5 minutes. Okay. In all of our training, how many times did you see somebody wipe the betadine on and then take an alcohol wipe and immediately wipe it off? They just wasted the betadine. It was almost nothing. Okay? Betadine takes 3 to 5 minutes to reach its maximum antiseptic effect. Chlorhexidine works in 30 seconds. And it has a broader antimicrobial spectrum, and it doesn't cause a brown goopy mess. So we use chlorhexidine. I don't even have betadine in the office anymore. So as far as that goes. Okay. Dry, fly, all of this is going to be dependent on what you're treating. Generally, there are no restrictions. We have people, I see people from all over the country. They fly in, they do the treatment, they go home the next day. Sometimes they go home that day, depending on where they're coming from. I have a family that actually comes from Indianapolis, and they fly out to see me. I have a patient who comes regularly up to Connecticut from Virginia. I have a patient from Bermuda. So I say, just use reason. That's really it. Just use reason with that, okay? What I don't like is if I'm doing a spine treatment, I don't want them getting in a car and sitting in the car for 6 hours and driving. If they're going to do that, at least get out every hour and move around, okay? So that's about it. This is the biggest issue that I have here, exercise. It's funny because I precept family practice residents in my office. I don't know if you have the same experience. I started a family practice residency, I hated it. Because all I was treating was COPD and diabetes and cardiovascular disease, and it drove me crazy. And in primary care, you're begging people to get off the couch to do something. Please move. In our practice, we have the opposite problem. Please don't. No, you can't go back to playing tennis. No, you can't go back to pitching tomorrow. We have the opposite problem of reining in these people, and saying, no, you have to allow time to heal. And by far, the runners are the worst. The runners are crazy because the runners don't want to come in because they don't want to be told that they can't run. So what they do is they put it off and off and off until their condition gets so bad that when they come in, you have to tell them, you can't run. So now it becomes a self-fulfilling prophecy. So runners are nuts. I mean that, facetiously. I love treating athletes, including runners. But you get my point? You have to give them some really strict guidelines. Okay? I actually have a return to throwing program by the New York Yankees that says on week 1, you can short toss 25 feet for 20 times. It's that specific. Okay? No, you cannot run for 3 weeks at all. Well, can I do some brisk walking with my dog? Well, what does that mean? Well, that means 3 miles through the woods. No! No, you can't do that if I just injected your knee or your hip. So that's the type of thing that we go through, okay? It's really difficult for athletes to rein that in, but I tell them, look, you're spending a lot of money doing these treatments. Do you want it to be wasted? Do you want to have to come back and do it all over again? No, doc. So what they end up doing oftentimes is scheduling their treatment during their down season, or as soon as their season is over, so now they've got that time to rest and recover. That's perfectly reasonable. Okay? We already talked about the arthritis medications, their home medications. Generally speaking, I don't limit their medications. The exception would be if I'm doing liposuction, I want them off their anticoagulants for a week before, and then they can start it back up 3 days afterwards. And I coordinate that with the prescribing physician. Okay? You don't have to do that if you're just doing PRP. Okay? The reason is liposuction, you're going into a lot of vascularized area, and I don't want them to have the bleeding. Okay? We can't stop all the pain. I think that's a reasonable thing to make sure. The only thing I tell patients that eliminates pain is arsenic. Okay? And I'm not going to give that to you. So to say our goal is to keep your pain at a level where you can manage it. Okay? Post-treatment. Right? In terms of reasonable expectations, I tell patients, because they say, when can I start to feel better? With PRP, my experience is gonna be about 4 to 6 weeks. With stem cells, it's about 8 to 10 weeks. Said it's gonna take about 2 to 3 months, even as long as 6 months, to see the full benefit of the treatment that we're doing. This is not an immediate fix. I'd rather under-promise and over-deliver. And I learned that early on. We made that mistake when we were doing osteoarthritis. We do one treatment. Yeah, it should work in about 4 to 6 weeks. Well, no, it actually takes 3 treatments and about 3 months to see improvement, really lasting improvement. Okay, so realistic expectations. Okay, and it's going to have one of these courses also. It's not going to be like this. You know, you're going to feel real good for a few days, and then it may backslide, and then you're going to feel better for a few days. So it's going to have this waxing and waning course. As long as the end is better than where the beginning was, you're moving in that course. Human beings are really funny, because they'll come in and they'll say, I'm no better. Well, what do you mean you're no better? When you came in, you were at an 8 out of 10 pain, and today you're at a 4 out of 10 pain. Oh yeah, my pain is less, but I'm still in pain, which means I'm no better. It's like, no, you got a lot better. Oh yeah, I guess you're right. You know, and that's normal. That's what happens, because you're 8 out of 10 here. Once you're at a 4 out of 10, that 4 out of 10 is now your new 8 out of 10. Your frame of reference changes. So being realistic and bringing patients back to say, look where you were. They're like, oh yeah, do that. Because otherwise they're going to say the treatment isn't working when it really is. And that's why, you know, in terms of research, just even if you do a VAS score, you can show the patient where they've come over time. Okay? None of that you have to worry about. By the way, smokers, they don't do as well, particularly heavy smokers. Their peripheral tissues are depleted of oxygen. They just don't heal as well. I will warn my smokers, you may not have as good a response. Ideally, we want you to stop smoking. Some of my colleagues won't even treat smokers. I'm not that hard and fast, but I do tell them it may not work as well.